All right, we're recording. So, Travis or Howard, would you like to begin?
I've got several cases. I don't know who else. I know David's not going to be here
Yeah,
this week.
I haven't heard from Seth, so we'll see if he joins us.
Okay.
Take your time. We got plenty of time.
The first three are actually all related. We've had a run on these cases. And so this radiograph came in, 38-year-old man who's had chronic respiratory symptoms. And once you've seen this a couple times, then it's easy to quickly identify this as an Ant Mini. You can see in this case, there's volume loss on the left side. And one of the keys here, the right aortic arch. And you don't really see much in terms of a left pulmonary artery. We can look at the lateral view as well, and you'll see that we see a right hilar vascular opacity, but you don't see the typical left pulmonary artery under the aorta. And so whenever you see this in conjunction with the contralateral right-sided arch, this just screams of proximal interruption of the left pulmonary artery. And so I talked to them. He'd had some prior radiographs, and they had talked about lung hypoplasia and all this. They'd never actually made the diagnosis. This was actually recently from an outside hospital. They had gotten a CT, and I don't know the backstory. They loaded it into our system, and I'm guessing that he had a pneumonia of sorts, it looks like. But sure enough, you can see that this confirms the diagnosis that he has a proximal interruption of his left pulmonary artery. So this is one that we've seen, over and over in these, and it's a lot easier to make the diagnosis when it's on the left because it's almost always associated with a contralateral aortic arch. And the question always comes up, like, why does this happen? Not to get too much into embryology, but remember that the pulmonary arteries, the proximal portions of the pulmonary arteries arise from the sixth aortic arch. And that's also what gives rise to the ligamentum or the ductus arteriosus and then the ligamentum arteriosum. And so that kind of sets the stage for the next case. I'll make one more comment. I think we can still see in him that probably, I don't know, since it's a non-contrast study, probably right here off the left subclavian, you can see something headed down a little that may be the ligamentum arteriosum in his case. You can see that he still has some pulmonary arteries, it's just the proximal portion is interrupted. So then this gets me to a case that was sent by a colleague. This was sent to both Seth and I from one of our viewers. And this is a crazy case of a patient, an adult patient, with a somewhat distorted anatomy here. And so when we see this one, you see the right arch is patent, and there is no left aortic arch. And when you look at the pulmonary artery, you see the same thing. The proximal pulmonary artery is interrupted, except in this case, we see that there is supply of this from the left subclavian artery. So in this case, the same thing happens where the proximal pulmonary artery from the sixth aortic arch regresses. But in this case, the ductus maintained its patency and is supplying this left pulmonary artery. What's also interesting, there's a right-sided ductus arteriosus in this case, communicating with the pulmonary artery and the aorta as well. But you can see this explains why I think this patient has profound pulmonary hypertension from a long-standing shunt. And there may be a little bit of a secundum atrial septal defect as well, but you can see how dilated and how hypertrophied the aorta is. So this is one of those cases that kind of explains how this develops, that the fact that the patient ends up with blood supply in the lung causing the pulmonary artery to develop via the ductus arteriosus. And then if it ligates, or if it regresses after birth, as normally happens, then you end up with proximal interruption of the pulmonary artery. And so that sets up this case, which was a recent, I saw a recent follow-up study on this patient. And I'll show you the first case from 2015. And this is you can see it's a young patient, 28-month-old. And in this case, you have a left aortic arch, and this is the harder diagnosis to make, but you see there's proximal interruption of the right pulmonary artery. But we still see a fairly well-developed distal pulmonary arterial circulation, and we see that there are some bronchial artery collaterals, no surprise, supplying that lung. But one thing I was looking at, and I think I have a delay that actually shows this better. Let me make sure. No, that's 2019. let me see. It's this right here. So I only have this one phase, but you notice on the arch that this is the brachiocephalic artery, and you see this little nubbin right here. It's kind of blind ending. And so the question that I had was, is this probably the remnant of the ligamentum arteriosum, or it is the ligamentum arteriosum, the remnant of the ductus arteriosus that formed the proximal portion of this pulmonary artery? And for whatever reason in this patient, I think probably because it was diagnosed early, they actually went in and repaired this, and they created a new right pulmonary artery. So I'll put these up side by side, and you'll see that, you know, because there is still a pulmonary artery circulation there, that they were able to reconstruct a right pulmonary artery. So they created a conduit, or implanted a conduit as the proximal pulmonary artery. So they've essentially, you know, repaired this patient's proximal interruption of the pulmonary artery. And when looking through the surgical note, sure enough, that little nubbin that we saw up here on the prior study right here has been ligated, and that was the remnant of the ductus. So that was the ligamentum arteriosum on the right. So it's kind of like several cases just showing where these proximal interruption of the pulmonary arteries arise from and how they develop. But this is the first one I've seen repaired. We actually have another patient that was repaired elsewhere that's been referred to us, you know, a young patient as well.
Yeah, no, the second case, I called that an isolated PA with ductal origin.
Yep.
That's a term that I use for those. I mean, it's super rare. It's only the second one I've seen. Yeah, no, it's a very interesting case that he had bilateral patent ductus.
Yeah. So why isolated as opposed to proximal interruption, right? Because it's...
Yeah, I just consider when you have a pulmonary vessel or a vein coming off an artery like that, I just refer them as isolated. I think there's a paper somewhere out there talking about it. I can try to find it. I might be wrong, but
at least in these, it's important not to say that it's just absence or agenesis of the pulmonary artery, because clearly that's not what, you know, it's the regression of the portion of the sixth arch from the ductus, you know, as they showed in this case, where they were able to reconstruct it because there's still peripheral pulmonary arteries. Yeah, Seth, if you could find that, that'd be nice.
Yeah.
Seth, now that you're on there, I'll show this one. Hold on one second. Just routine is fine. All right, so this I've never seen this manifestation of this before, and I'm curious if anyone else has. But this is a patient, 65, who, let's see if I can find his abdomen first. In 2011, he was diagnosed with pancreatic insufficiency. You can see his pancreas is really wimpy here and atrophied, and he was eventually diagnosed with, well, this was just attributed to autoimmune pancreatitis. You can see at this point, he has some scar around his kidneys, and unfortunately, I don't have any of this imaging, but he had bilateral renal masses that were biopsied back at around the same time, and it was all eventually determined to be IgG4 lymphoplasmacytic infiltrate. So he was diagnosed with IgG4 related systemic disease. Also around that time, he had a stroke and was found to have a left carotid artery aneurysm and dissection, for which he received a stent, as you see here. But the kicker of this was what I will show you now, which is his coronary arteries, and in particular his left anterior descending coronary artery. And he's had this since 2013, but you can see this
oh my goodness,
soft tissue extending along the entirety of his LAD and his diags and his septal perforators here. So this was 2013. Now he's been treated with immunosuppression off and on. 2019, here I've got a PET CT from just last week, which is how I found this case. And now you can see the stuff has actually increased, that there's more soft tissue than there was even in 2015, or 2013. But I guess, I mean, this is all being presumptively treated as, you know, IgG4 related systemic disease involving the coronary arteries. You can see that Well, if I can sync this back
I think
up.
picture. I mean, that's pretty freaking impressive.
Yeah.
I've never seen anything vasculitis, or I don't even know if IgG4 is considered vasculitis, whatever it is, an infiltration that I've never seen that. That's pretty crazy.
Yeah. So I don't know what they're going to do about it at this point.
Has he had like a stress test? Does he actually have, because it doesn't look narrowed. It just,
No.
the vessels actually look really.
Right. And I know you've shown cases of like peri-aortitis from IgG4, and I think I saw one at Emory, but like this is just crazy.
Yeah, that's pretty impressive.
So,
wow.
But that's what it's being treated as presumptively as it's just of a small to medium sized vessel instead of the aorta. So
that is remarkable.
I'll show one more here, and then I will stop for now. This is one I saw last August. And this is a patient who has had a liver transplant. He had some focus of hepatocellular carcinoma. So he's getting surveillance CTs looking for metastatic disease. And I saw this, and he's got a cluster of nodules in the left upper lobe. And sometimes our restaging exams can get a little exciting. You look back and you see there's something faint there 6 months prior to that. And just because he was immunosuppressed, I was more than just run-of-the-mill infection. I talked to the clinical team and said, has he been worked up for fungal pneumonia? Does he have symptoms? Could he have TB? He didn't get follow-up at that time. He was supposed to see a pulmonologist, then got this CT 6 months after that. This was actually done elsewhere, but sent back to our tumor board. And so I saw this one as well. And you can see these clusters of nodules are actually worsening a little. And so I had the exact same discussion. They finally got him in at an outside hospital for a bronch because he was asymptomatic. And this did grow Mycobacterium tuberculosis. So he's originally from Mexico. And so his low-level immunosuppression certainly put him at increased risk. And you can see that the nodules have slightly worsened over time. One question I have for you guys, I think, it's always important to not forget about TB in particular in patients that are immunosuppressed. It's kind of hard, and I like to show this one to my residents. And there's often struggle between differentiating, is this all central lobular, is some of it perilymphatic, or is it a combination of both? Because there are maybe a couple nodules that dot the fissures and the central lobular and the pleural surfaces. I mean, I would argue it doesn't really matter because they look, certainly since TB can do both. But I don't know if anyone has any comments.
Yeah, so Travis, it looks, I agree, it looks like both here. And, we see this with histoplasmosis where you see the dominant nodule and you'll see little nodules along the draining lymphatics. And over time, we'll see that even the calcified nodules go that way. So it doesn't surprise me. It starts as a bronchiolitis, and then you get sort of a TB lymph, like a lymphangitis that goes along with it. Did he have any lymphadenopathy in that draining pathway?
No.
Okay.
Nothing. So, but yeah, just another reminder to always be on the lookout for tuberculosis, especially in immunosuppressed patients. So, okay, I'll stop there for now, Jeff.
Cool. Thanks.
Very nice.
All righty. Who would like to go next?
I'll go.
All right, let's see here. There you go, Seth.
Okay. So this just real quick. Wait, wrong one. Where'd it go? Here. This is the paper. I just found it. Talking about what Travis was talking about. I actually had 37 people who had this, which is nuts. And they basically say that when in isolation, this lesion is usually unilateral absent PA, but we prefer isolated PA of ductal origin. Basically saying because of the embryology that this involves disruption of the sixth arch. Anyways, it doesn't matter, but they say it's because the pulmonary vasculature is completely normally formed except for that proximal portion, and this this is what they prefer to call it. And I just remember, but it's kind of splitting hairs. It's
Also,
whatever.
Yeah. So I guess the interrupted pulmonary artery is when the ligament or the ductus then, atrophies as well or regresses, right? Because this is saying still has ductal supply via the systemic circulation in these.
Yes.
Yeah. Okay.
I get, but I don't think anyone would.
Cool.
Okay, so real quick case. I don't think I showed this one last time. But, this is just one of the. Unfortunately, we don't have a CT for this, which I was very upset about because it would have been really nice. But if I can get this bigger, and let's see if I can get the lateral up, which of course I can't because Terracon stinks. But there is that is not external to the patient. We use paper clips to mark something. Here's the lateral, which will give away where this is. And if you wonder how a 3-inch sewing needle winds up in the heart, well, we're all befuddled by that one. You can see the nice little loop if you want to loop some thread on there. Supposedly the kid was walking down it was like an 18-year-old. Supposedly he was walking down the stairs and tripped and fell. And there just happened to be a sewing needle sitting straight up in the carpet, which then impaled him and went into his heart. It was confirmed to be in his heart on surgery, but I don't have any pictures or anything, but a nice case of a needle in the heart.
That seems like a suspect history.
It totally is. I'm saying you're like,
That's like the foreign body that ends up in the rectum because it just happens to be like vertically oriented.
We were like, at what point, did your mom get upset at you when you were sewing, or did you steal her sewing equipment, or was this some sort of torture? I don't know, but we're sticking with the fall from the third stair straight onto a sewing needle on the ground. So this is a really cool case because it's just something I haven't seen in 5-6 years. But you can see that there is a bioprosthetic aortic valve, and we also noticed that there is this mass here within the mediastinum. It's hard to tell if it's vascular or what. We also don't see kind of the really normal arch, and you can see that this is going down along the course of the descending thoracic aorta. And this is the CT, which nicely shows a normal looking ascending aorta, and then you get up into the arch region and you see that we have this very large kind of overly tortuous aorta, and show it kind of a little bit on here on the and the thing to notice is that A, there is no real significant narrowing, and B, this is not a this is a pseudocoarc, or at least that's what I would call this. And you can see that there's just an abnormal elongation of the aorta, that this isn't an actual ductal tissue. There's no, coarctation, there's ductal tissue, or presumed to be ductal tissue, that wraps around the aorta and the ductal region that causes, that when it contracts, causes coarctation. This is actually an embryologic overgrowth. I'm not sure the underlying embryology, but basically the aorta between the left common carotid and left subclavian artery becomes very, very elongated and has nowhere to go. And you basically get this folding over of the aorta. So, this is only, I think, the third pseudocoarctation I've seen. Just a nice example of that. And just remember that these are not associated, even though there's kinking of it and a folding of it here. You can kind of see where it folds over on itself, that these are not obstructive. And the other big differentiation, of course, is that because it's a non-obstructive process, that there's no collateral vessels. And the other thing to remember is that just like coarctation, which is interesting, these are associated with bicuspid aortic valves as well. Very high association with bicuspid aortic valve, which is what he had. Unfortunately, we cannot tell yet a bicuspid valve. We can just see that it was replaced. But that is a nice case of what I would call pseudocoarctation. I don't know if you guys would agree, but that's what I called it. This is a case of a young woman who unfortunately was diagnosed with thyroid cancer and has a pre-op normal chest x-ray, and then post-op develops these large pleural effusions. You can see the drain here, obviously, and then we get into the CT, and we get into these very large bilateral pleural effusions. One second. Large bilateral pleural effusions, and here is the associated, let's see if we can do this. See if I can get this to play correctly. This thing always gets over my... So here is the lymphangiogram that they did. Somehow they literally put a catheter. I don't even know how they got a catheter into this duct, into the thoracic duct, but you can see that they are squirting up, in contrast is going in the wrong place or not going into the appropriate place, and is basically extravasating. And they actually very nicely coiled this. So these were massive bilateral chylothoraces. If you hold on one second, I'll show you the lab values from thoracic duct injury, from thyroid surgery. So I had never seen them bilateral before, but let's see here. So here's the triglycerides from the pleural fluid. There's the cholesterol. I asked what normal was for someone. They said 0, that there should not be any cholesterol in your pleural fluid nor triglycerides. And then here's the fluid type. And they did a really nice job. Here's the post-treatment radiograph, where they basically coiled, embolized the thoracic duct, and her effusions resolved. I don't know what the long-term sequela of this is. I would assume that there would be other lymphatic pathways would form, but I'm not sure. And I don't remember. Oh, this is just a really scary case because, and I can't remember if I showed this before or not, but it's just worth repeating if I hadn't. So here is a patient who comes in with a little bit of chest pain and has this in her left lower lobe PA. And, I think this is not a PE study. This is from an outside institution. And you can see that there's just this layering soft tissue here. The vessel distal to that is gone. And I think if I saw this now, I would just call this chronic thromboembolic disease. And so that's, honestly, I don't even know if it was caught on the outside study, but she comes back many months later with worsening chest pain. And now that little thing that looked like just an eccentric focus of thromboembolic disease has now grown up into her left lower lobe PA, and she has this massive infarct. And this massive infarct actually caused a pneumothorax, which is pretty impressive. And believe it or not, on the outside, this was still called persistent pulmonary embolus. And then she came here, and we did some. It kept growing, and it kept growing outside the vessels, and you can see that all these vessels are expanded. It's growing out. Unfortunately, they biopsied this. Well, they didn't biopsy. They took her for endarterectomy. Let me see if I can find the. One second, guys. Let me see if I can find this. And here's what they pulled out of the left lower lobe. Honestly, to me, it looks like just like every clot they pull out, but they said it's very different feeling. It's like gelatinous soft tissue. Unfortunately, they biopsied the left, and there was no disease. And she got a pneumonectomy, and she has done okay. We'll see if it ever comes, if she's developed Mets before. She had Mets before then, but fortunately she was a PA sarcoma that may have a good outcome because it was isolated to left lower lobe. But a very scary case where I don't know if anyone, and this is the third case I've seen like this with, where they start out like this, just growth along the side of a lobar or segmental vessel. So pretty scary case.
Hey, Seth, quick question. I think you were not on a couple weeks ago. I showed an aortic sarcoma, similar to these. What's your distinction between an angiosarcoma and an intimal sarcoma? Because like in this one, it was like an angiosarcoma, which my understanding, I guess, is just that they're more aggressive than intimal sarcomas, or do you know if there's
I have not seen many. Most of the sarcomas I see are purely intimal sarcomas. I don't know if I've seen an angiosarcoma. Of all the pulmonary artery cases we have, I don't know if any were angiosarcomas. We had a lot of, we've had an osteosarcoma, we've had a chondrosarcoma. I haven't seen an angiosarcoma.
Because
But
I
again,
guess I'm confused, because it seems like an angiosarcoma would be arising from the vessel, and that that it would be similar to an intimal sarcoma, right?
I'm not, pathologically, I'm not 100% sure what they would look like. Because I'm trying to think of the matter of differentiation, because I mean, I guess it could differentiate into an angiosarcoma, but I'll ask pathologist what he says.
Okay.
But, yeah. Anyways, Jeff, sorry, those are my cases.
Thanks. Excellent cases. All righty.
Excellent.
Howard, you ready?
Okay.
All right, there you go.
Okay, this is a case I saw the other day, and I'll give you a moment to look at that. I did describe abnormality in the left lower lobe, and that's all I described. And that's not the dominant finding. So take a look at that for a moment. The lateral projection I will bring up alongside, but it's not that helpful. But there it is. But the key for this case, I think, is appreciating that this is gas in bowel. I can't tell for sure. It's probably in stomach. But between here and where one might infer the left hemidiaphragm to be, and here, is too much opacity. There's a lot there. And here is the image from a CT that was done soon thereafter. Let me just fix that up. Bring that back again. And you can see that when the person is recumbent, that the pleural fluid that is subpulmonic in location, that is here, flows out right there. So this is a really nice example of a lot of left subpulmonic pleural fluid. And certainly on the left side, if there is gas in bowel and there's no other subphrenic pathology, that's the tip-off that there's something here. It's not just this that has to be accounted for. So this is a nice example of a substantial amount of left subpulmonic pleural fluid. And it turned out to be associated with a fracture, and that is the left hemothorax. Here is a displaced fracture down there. So a really nice example of remembering the idea that one can diagnose left subpulmonic pleural fluid sometimes by looking at the stomach and being aware of where the diaphragm is and the base of lung is. So these are two really nice cases. So let me first show you the more severe one. So the story is that this person was ill around the 21st of June and went to an Instacare. I'm not sure what was diagnosed, but you'll see in a moment that he got progressively ill rather quickly. So I'll bring up the CT from the next day, when you can see that his lungs look like that, just extensive consolidation. He also has pleural fluid. And then I'll show you that he was transferred here for acute respiratory failure. So this now is the 23rd of June. And you will see that he eventually ended up intubated, but also on veno-veno ECMO. So here you'll see the placement of that cannula. So now his lungs look like that. Now, this in part is just presumably poor aeration of the lung. Maybe, I don't know what the ventilator settings here, but he has acute respiratory failure and veno-venous ECMO. So now I will bring up here Bronchoalveolar Lavage, and you can see what's interesting about this one is that macrophages contain lipid, as you can see there. And then look at this history here. He was coughing for 6 days, coincident with trying a new vape juice. And that's what happened to him. So he has severe vaping associated lung injury requiring that. And amazingly, this is what he looks like on the July the 10th.
Wow.
So,
did they think any component of this was acute eosinophilic pneumonia?
so let's have a look at those eos.
I saw there were like 10% eosinophils or 12% there.
No.
And on that first one, it kind of looked like there was septal thickening and looked like hydrostatic edema, but it wasn't.
On the CT?
Yeah, because you had effusions and you had septal thickening in addition to all of the other stuff. That's why I wondered if that was a component of this.
That could definitely be acute eosinophilic pneumonia. Absolutely.
Yeah.
And even some of that down there is, it definitely could be.
But maybe a component of this is also just acute lung injury because he's got mobilizable pleural fluid. Presumably, the pleural fluid has come from the lung, I assume, has come from the lung. So there is acute lung injury and lung water. But how much of this is eosinophilic pneumonia? I don't know. I don't know. And
did they start him on steroids? Or how did they treat him? Because, I mean, that's a pretty rapid response.
Yeah. I can't remember. I don't know if they did or didn't, but he did get better. So then part of the question is, where does the fat come from? So, here's the recipe for making your vape juice. So it turns out that you can combine these things to make vape juice. So you need this, or this, and this, and the flavoring and the nicotine. And the fat, presumably, that they find in the macrophages is the vegetable glycerol. So you can see that people use different amounts of these two items in particular. And if you want a dense vapor cloud, you can add more of the glycerol. But I presume it's the glycerol that ends up in the macrophages. But this is the first case of severe acute lung injury. I don't know how much of it is eosinophilic pneumonia from vaping.
Can you see, do you have a case, can you find out when he was given steroids and how fast the improvement was after that? Because that's the hallmark of eosinophilic pneumonia.
Okay. Yeah, I'll try to find out.
It's really interesting to see.
How much of that is an eosinophilic pneumonia? Yeah, I'll try to find out. So it turns out that not long thereafter, here's another person. This is coincidental. So let's take a look at this one. This one is June 11. He got ill, and I don't have radiographs between June 11 and 27th, but look at his lungs over here. Look at this person's lungs. And let's take a look at his parameters here. Let's see what I have for the cell count, 3% eosinophils here. Now, after this was done, and we had the previous case, I suggested they could look for the fat again. So they did the fat afterwards on the same remnant fluid and bronchial lavage. And he's also got fat in 25% of macrophages, but he has 3% eosinophils. And again, this is considered to be another case of vaping-associated acute lung injury. And the CT I showed you was from the 27th. Here's a chest radiograph. And he got better too and left the hospital. So there's a day between these two radiographs. So again, here, a clinical diagnosis of acute vaping-associated lung injury. Let's see what the history was here. He had all these things that were negative, but he was also a vapor.
Howard, it doesn't surprise me. I showed a case not too long ago of a vaping-induced lung injury as well. I think a lot of it depends on what's in this stuff. And it injures the epithelium, and then we all know what happens there, like any other inhalational injury.
The one you showed previously was thought by you guys to maybe be pulmonary hemorrhage, maybe because he had hemoptysis.
Yeah, perhaps, you injured the epithelium into basement membrane, but yeah, I'm surprised we don't see more of these, given that the compounds have all sorts of different, things. I mean, there was that one study, it was a couple of years ago, that showed I think they tested like 160 different vaping compounds, and a fair number of them had diacetyl, which can cause constrictive bronchiolitis. So something to always think about.
Yeah, I guess we're going to see more of these as we go along, right?
I'm kind of surprised we haven't seen more, but it may be they don't. I don't know. I mean, I would think, when you see smoking histories, I don't see vaping very often.
Yeah. There's a little bit more lymphoid tissue than we usually see there, but I don't know what that means in this context. Maybe it's a reactive hyperplasia if he's been vaping for a long time. Some kind of reaction to it. Okay, those are my three.
All right.
Jeff?
Thank you. All right, so I've got to.
Hey Jeff, can you pull my screen up for 1 second? I'm sorry, I'll be real quick.
No worries. Go ahead.
So someone asked me, would any of you guys call this a cervical arch? And to me, it's folded on itself, and it's kinked, and the arch does go high. And would you say this is a cervical arch versus a pseudocoarctation, or we've been reading things that say that the two can occur together? What are your thoughts?
Well, it's what are I mean, typically cervical arches have funny branch patterns of the carotids and other things, because of it's a different persistent embryologic arch that contributes to it. So that's something that can be helpful. That one's I don't know. The pseudocoarcs are often very high riding arches. I've seen.
They are. Yeah, and I've seen two cervicals. One of them was Dave's case, and they were way up here. But again, I'm an NF2, so I would just call this pseudocoarc and not a cervical. But I didn't have a good reason as to why it's not.
I would call it high riding, to be honest. I don't think it's quite up because the cervical arches are practically in the neck.
Yes, that's exactly. Yeah, the ones I've seen are way up there. Okay. All right, cool. Thanks.
Yeah. All righty. Okay, so let me start with this case. This is something I've never seen a CT of before, but something we have a lot of here in Wisconsin. So this is a 39-year-old female who presented with, she said, a spider bite on her arm and developed some sort of swelling around it. So she went to an urgent care somewhere, and they treated her for like a cellulitis with cephalosporin, but she wasn't getting better. So she returned about a week later, and her rash had gotten worse, and her arm was swollen more, and she developed sort of axillary swelling. So eventually they sent her to emergency department, and the CT was done because there was fluctuance and palpable mass in the axilla. And you can see right here, you guys can see my screen, right?
No, we can just see your database window.
Oh, that's weird. Okay, I was a little worried about that. Let's see. There.
Good.
Now we go. All right, but you can see there are these axillary lymph nodes, and they're nice and round. They're a little bit low attenuation in the middle, but nothing else. No mass in the chest wall. Nothing like that. So given her presentation, it's probably just an infectious lymphadenitis. So her history was spider bite or something like that. So you would think about maybe, I don't know, something else, cat scratch disease. But interestingly, the emergency physician acutely figured out this was a different infection and sent off an IgM level for Lyme disease. And let's see if I can make it show you here. And then you can see here. So there's a IgM antibody to the correct organism. I forget what the genus is, but
Borrelia.
yeah, Bergdorferi. But this is what causes Lyme disease. So treated her with doxycycline, which is the appropriate treatment for Lyme disease. And as far as I can tell, it's already improving. But I found this interesting too. There's significant cross-reactivity with a whole bunch of other infections. There's also an IgG level, but there's depending on how long the symptoms are going on. And it also says you don't order this test to see if it's been cured, because it doesn't work for that. But it's very interesting, because this is a Lyme disease lymphadenitis, and I'm not aware of that ever. I've never encountered it, and we're a Lyme disease hotspot, especially this time of year up north in the woods, and also even the Arboretum in town here has a high rate of Lyme disease. But I don't know if you guys ever encountered. I've never seen this degree of lymphadenopathy from something like this. Okay, well, that's my first case of this.
No.
All right, this was a case that was sent to me by a radiologist in Kashmir, in the Indian portion of, well, I guess in the state of Kashmir in India. This is a young patient. I don't know exactly how old, but looks pretty young, and presented with cough, and you can see has these sort of cavitary lesions. I'll show you on soft tissue as well. This is converted from a movie file, so I can't window and level them, but you can see some of them are very tubular, and there's extension here into the mediastinum. There's gas, and this one's kind of cool here, because I was trying to wrap my head about where these are. So we've got a pulmonary artery, we've got this tubular structure, and then we've got the airway. So it's kind of sandwiched in just next to the airway. So you can follow the airways following this. So I can't figure out if this is arterial, or if this is, I think it may be lymphatic, this stuff. And now I'll show you the soft tissue window settings, if it'll pull them over. Okay, don't crash on me. Here we go. And they're extremely low attenuation. I mean, very, very low attenuation. And then you can see this pretty striking bronchial artery hypertrophy as well, which is, I mean, almost like the level you see with cystic fibrosis and longstanding bronchiectasis. So they biopsied this, and anyone want to hazard a guess what this ended up being?
A tropical disease.
Well, Kashmir is actually very mountainous, so it's not quite tropical there, but apparently they have they see a lot of this infection there. But this is a case of hydatid disease in the lung. Yeah. And, I've seen, I think maybe it was you, Seth, showed a case of a cyst in the lung that was a hydatid cyst. And, people have described liver lesions that have extended into the pleural space or ruptured into the chest. But this is primary, as far as we can tell, there wasn't any liver disease. But this is just multifocal. And the radiologist was telling me that usually it presents as a single lesion in the lung. So this is a very unusual case.
I've only seen it with a solitary.
Yeah. So I don't know. I don't know enough about hydatid disease, but they are thinking about, I don't know what just happened here. They're thinking it may be what do you call it? Alveolar type or something like that. Okay, so let me show you. This is something else crazy I have never seen before. Let's see. So this is a patient. I'm going to show you an old CT first, if this is the right one. No, that's the wrong one. Okay, and then I'll show you. So this patient had a right upper lobectomy a long time ago, and has had problems with a bronchopleural fistula. And this is a nice example where you can actually see the bronchopleural fistula. And it's thought to be complicated by non-tuberculous mycobacterial, and that's what sort of all this brouhaha is in the lingula and elsewhere. And those nodules kind of wax and wane, and they've never really been able to get that under control. And you can see the middle lobe is pretty trashed. So they've tried to treat this bronchopleural fistula. They tried drainage, and then they ended up putting a muscle flap in here at one point, and it didn't do well. So they came back for a bigger flap. So they put a latissimus flap in, and here is a radiograph where there's a bit, you can see the muscle flap here. I tried to get the more recent radiograph, but I'm having export issues on that particular file, so I'm going to try a couple other things before I send it along. But what's really cool, so the patient was having more gas leaking into the chest wall. You can see there's a drain in here. So the presumption is this flap wasn't doing what it's supposed to be doing. And you can see there's the bronchopleural fistula. Where in the world is this muscle flap that's supposed to be there? Well, it's actually sitting here down in the chest wall, just kind of hanging out like a torn biceps tendon in this pocket. This is the latissimus just all balled up. I've seen a flap break down, but I've never seen one actually pull out of the chest and recoil into the chest wall. So now there's this big communication here. So this is going to be a tough one to deal with, because this space is just this constant communication. You can see there's all this subacute gas, and now you've got a muscle flap hanging out here, and that dehyst right off of this covered area here. So I don't know. Have you ever seen a muscle flap? And the subsequent radiograph actually shows that the soft tissue is gone.
Nope, never seen that.
Yeah, I had neither, but
or anything quite like that. No.
Yeah. That's going to be tough to manage. I don't know if they're going to have to externalize that cavity and just do like a LOS or flap or a Claggett.
I was say now he has an LES or flap, because
effectively he does. It's just not all tidied up.
There's a defect right there. It remains. That's awful.
Yeah, it's a Bronco Pleural chest wall fistula still. So okay, so that was a little bit crazy. And then this is a case of I think he's a 50-something-year-old male patient who was having some PVCs. So this was a coronary CT that was done. And what was noted on the coronary CT, there's no plaque, but if you follow the left circumflex down, you can see this little branch, or I guess it's not the circ, but a branch here, and maybe an OM branch right there coming off the circ. You'll see that there's what looks like a thrombosed aneurysm, and then the artery, this little artery continues. But what's really kind of cool, and I'll see if I can window it right, is if you go down a little bit further, I think I got the right series, there's a little thinning right there distally. So there's a little old infarct, just like a very small territory, infarct just distal right there off this branch. And turns out, from what I was told, that the PVCs, or the source of the PVCs, is mapping to this area of the myocardium. But so the question is, what kind of coronary? First of all, I don't know what they're going to do with this. That's a question probably for the cardiologist. Do you do a cath? Do you put a stent across it to prevent it from doing anything? It looks pretty thrombosed at this point. You'd wonder, is this? I mean, I was wondering, is this old Kawasaki's disease that just was never diagnosed? I've seen one or two cases of Kawasaki disease, and they looked very similar, except it wasn't thrombosed, but it was in the LAD. But it was a very focal, discrete, and it's been there some time, calcified aneurysm. So I don't know if any of you guys have any thoughts on this case, because there's no atherosclerosis anywhere else. You can look at the right coronary. I mean, the coronaries are pristine.
Yeah, I mean, these usually get labeled as old Kawasaki's without having, it's just like kind of how every vasculitis in a young patient gets labeled as Takayasu's, or large vessel vasculitis gets labeled as Takayasu's. These get labeled as Kawasaki's. And given the fact is, it may have been, I mean, who knows, but we see these occasionally, and the same thing, we don't know what to call them. But they often get labeled as that.
I mean, yeah, because I mean, I don't know if, I don't know how common Kawasaki's is in the U.S. Like I said, I've seen a couple cases in my whole career that had coronary aneurysms, and if it's some childhood illness that just gets labeled viral illness, and but there's no documented any incident.
Right. Yeah, when we see them in like 18-year-olds and 20-year-olds, and same thing, they have coronary aneurysms, but there's no history of anything. It's just they have a coronary aneurysms, and you assume that that it must have been Kawasaki's. But there's no documented illness when they were young. It's just what they get labeled.
Yeah. Cool. Yes, I don't know. I don't know what they do with these. That's not something I know, but it was kind of an interesting one as well. Okay. So those are my cases. Anybody else we have time if anybody has one more they want to share, or we can call it
I can show a couple more.
Okay. Oh, I just found out there's going to be a cardiac MRI done next week, so we'll get some more information.
I'd forgotten to include this. This is a case from the literature of IgG4 periarteritis. So instead of periaortitis, it's surrounding the coronary arteries. You can tell it's not a radiology journal given the excessive use of arrows to indicate the very obvious abnormality there. But similar to this case, a little less dramatic, I think. I'll show, this is an interesting one. Just
I love arrows, man. I use a ton of them.
This is one the CT is not that interesting. I just saw the CT, and this guy, he's got prostate cancer. He's in his 70s. He's got a small effusion. His LV is a little thick. The interesting thing about him is his bone scan, and I don't know why it came up in red, but it looks cool. And you can see he has myocardial uptake more than his kidneys. And so this was actually called prospectively on a prior bone scan. This other bone scan looks the same over the course of them. But back in 2016, when the nuclear medicine people saw this, they suggested the possibility of this being due to cardiac amyloid deposition. And on the CT, they did a subsequent fat pad biopsy and confirmed that he has transthyretin amyloid. So he's got a little bit of diastolic dysfunction and small effusion. And I think we often see this occasionally. I'm not going to diagnose it based on the CT, but there's a little bit of decreased enhancement of the subendocardium from that. But I didn't, it's been a long time since I've thought about bone scans, but in that context, but you can see it as with cardiac uptake, specifically transthyretin.
And knowing that diagnosis, you can almost make the fact that there's thickening of the atrial walls as well. But yeah, I mean, who knows? But
right.
We see that all the time. But yeah, I didn't realize that it was hot on bone scan. That's actually really cool. I had no clue.
They're looking through older reports too. They talk about how heart failure could give you uptake on bone scans, but you wonder if it's just because so much of transthyretin amyloid is underdiagnosed in older patients with unexplained cardiomyopathy. If a lot of those, like bogus textbook chapters from 20 years ago, just
this is a technician bone scan.
Yeah, and I pulled up. Yeah, so
why does it?
Bisphosphonates can accumulate in patients with transthyretin amyloid. I found one case series here.
Oh, fascinating. Okay, never knew that.
So random thing to add to the differential. It's kind of fun. Two cases really quick. This is an interesting case. So this was one at the end of last year. This patient presented to an outside hospital. They're like 12 years post-renal transplant and presented with acute onset of right-sided chest pain. And you can see that there's something that shouldn't be in the brachiocephalic vein going through the heart into the IVC. There's also a second metal fragment here of a catheter or of a wire. And so no surprise, this was a hemothorax at the outside hospital. And you can see the catheter fragment that's in the right pleural space. And it's separate from the one that's in his vena cava. And long story short, the last time the patient remembers, or the last time they could find out that he had a line or a wire was 9 years ago. I don't know if this is true or not, but this was a radiograph from when he had a line placed. And you can see there's a wire in the line. And I think that you'll see that the hub of the line of the catheter is probably here. So this is probably was left behind at the time and not recognized on this. But I don't think prospectively that if you just see this for line placement, I think I'd probably comment that there's still a wire, not knowing that it may be sucked into the catheter at this point. But apparently this had been there for 9 years before it actually presented with anything, assuming this is the culprit. So that was kind of just a quick one. And then this one was just happened to be coincidence. This patient had a chest x-ray. He was an outpatient, and one of my residents was looking at this. The clinician had called to look at it, and I happened to be looking over his shoulder, and the first thing the resident looked at was the pelvis and hip x-ray. And I noticed this, which had just been described as a catheter, on the hip x-rays, which we weren't reading. And then you look at this and you see, this thing looks like it's in the femoral vein. He had prostate cancer. So we, called up the people that had interpreted this, and said the clinician said the patient didn't have any sort of catheter there, had previous catheters, and sure enough, they did a CT later and found he had an IVC filter, and it may be that the IVC filter was preventing this retained wire from migrating any further. But this was another unsuspected wire from who knows where. But just two retained wires there to finish off.
All right. Well, thanks, everyone.
All right. Cool, guys. Thanks.
Yep. Talk to you next week.
Great cases.
Bye.